morning, everyone. It's a pleasure to be around everyone here. So let's start the discussion, today's discussion of greater tuberosity fractures. So greater tuberosity fractures are injuries that we come across quite frequently in our routine clinical practice. Yet they keep challenging us in terms of diagnosis, management, and outcome. So today, let us look into detail of how this greater tuberosity fractures are important, and let's see the management protocols. So isolated GT fractures, they comprise 15 to 20% of all the proximal humerus fractures. And most commonly they are associated with a fracture dislocation. So while assessing this greater tuberosity fractures, we also have to look at other associated injuries like glenoid fractures, labral injuries, and also the plexus injuries. In contrary to the proximal humerus fractures, which occurs in old osteoporotic bone, this isolated GT fractures tend to occur in young patients with a high energy trauma. If we look at the modality of the fracture, the mechanism is basically the avulsion injury. What is an avulsion injury? Is a tear of the bone from the parent bone. So what causes this displacement here is the attachment of the cuff tendons. According to a study conducted by Sugaya et al., we found that the footprint of supraspinatus on the greater tuberosity is substantially occupied by a significant amount of infraspinatus tendon. Therefore, when there is a fracture of the greater tuberosity, there is not only superior displacement, but there is also a posterior displacement of the fracture fragments. So how is it important? How does the displacement matter? There was a study conducted, and according to the result, the conclusion was there was poor outcome with the posterior superior displacement when compared to the isolated superior displacement or undisplaced fractures when it was treated conservatively. This was one of the pioneer article by Sir Charles Neer in 1970s, where the description of ideal 1 centimeter of the displacement and 45-degree angulation came into picture for the surgical management. But does this really holds good in the greater tuberosity fractures? Let us know what biomechanics says. So one of the study conducted by Bono et al., which was published in the JBJS journal, he evaluated the minor displacement of 0.5 centimeters, minor superior displacement of 0.5 centimeters can increase the abduction force significantly by 16%. When the superior displacement was combined with the posterior displacement, again the force increases up to 30%. So we have the classifications like most commonly used Neer's classification and AO classification. In 2014, Much et al. Proposed a morphological classification using a series of 199 isolated greater tuberosity fractures. So this morphological classification helps in understanding the mechanism of injury, the direction of the displacement, and also guides in the treatment protocol. According to this, the fractures are classified into 3 types. First one is the avulsion injury. It is basically like a rotator cuff injury, but it has a bony counterpart. Second one is split type of injuries. It is usually caused by the impact of posterior greater tuberosity on the anterior glenoid rim while dislocation. Third one is a depression type of injury. It usually resembles like a Hill-Sachs lesion, but it occurs more laterally. So it's always good to consider the radiological views. When we take a conventional AP view, there is always a 15 to 20 degree of the scapular tilt to the coronal plane. So always we'll get a osseous overlap. And even when the arm is internally rotated, we can confuse the calcific deposition or calcific tendinitis as a greater tuberosity fractures, and it can be missed. So in a study conducted by Ogawa et al., it was found that around 59% of isolated GT fractures goes unnoticed. Therefore, we'll need a couple of other more X-rays view for the diagnosis. One might be the Grashi's view, that is a true AP view. Here we can get to know the superior-inferior displacement, and other lateral views like axillaries and Welpe view, where we can get to know the anterior-posterior displacement. If it's not clear with the X-ray, we can definitely go and get a CT scan done. CT scan also gives us a better picture of the fracture and also the direction of the displacement. Whom to operate? So according to the American Academy of Orthopedic Surgeons, Any fractures up to 5 millimeters of displacement can be treated conservatively in a low demand patient. But in a high demand patient, the displacement as less as 3 millimeter can be considered for surgical management. There are a couple of other ratios which are used to know whether the fracture can be treated surgically or conservatively. One is this GT ratio. If it's more than 5, has to be treated surgically. Other one is the impingement index. If it is more than 7.7, it can be treated. Like it gives better results when treated operatively. There are spectrum of fixation techniques from percutaneous to arthroscopic methods. It all depends upon the age of the patient, level of activity, what is the expected outcome from the patient, and also the condition of the bone. Percutaneous methods are used when the fragment is large and the bone stock is good. So various indirect reduction techniques, as explained here, can be used to reduce the fracture and fix temporarily and percutaneously with a guide pin, and then we can put a CC screw. Various other methods of open reduction are CC screws, tension band wiring, and we can even use the suture anchor or a GT plate. So in spite of getting an ideal fixation, when you start mobilizing the patient, we often see the patient come back with a failure of implant. So the screw must have cut out and the fragment is again superiorly displaced. So in order to avoid that, we can do a secondary fixation method called the lateral fixation. Here the sutures are taken, they are passed from the rotator cuff tendon and it is anchored distally at the level of the surgical neck of humerus, either with a knotless anchors or it can be tied with the cortical screws. This will offload the primary fixation and aids in the faster mobility.
Summarize.
Others like proximal humerus plates can also be used. Arthroscopic technique can also be used for repair of the GT fragment by suture bridge method. So according to the American Journal of Arthroscopy, it has given the classification like what fractures has to be treated in what way. Like avulsion fractures, it's better to use a transosseous technique or a double door repair. In a split fracture, there are various treatment options, like even a plate can be used or CC screws can be used. In depressed fracture, it can be treated non-surgically. So according to like the take-home messages, the fractures of GT may be surprisingly tricky than seen on X-rays. Proper identification of the direction of displacement and the degree of displacement is essential. It can be managed conservatively if the displacement is minimal. And there are wide spectrum of treatment available for the management. So using the rotator cuff tissue for the fixation helps in reduction of the fracture fragments. Thank you.
Thank you, Dr. Sindhu.